this will be discussed when we talk of antifungal agent in one of the session. I think you had that already.
Last night.
Last night. Okay. So more or less you have the idea on the antifungal. Okay. Let us talk first about fungus. Who are they in the first place? So your fungi are molds and yeasts that are widely distributed in the air. So you can breathe them from the dust, from fomites, and it may be part of the normal flora. So now that it rained, look at them in your house. So sometimes you can see them growing. Those tiny little dust there are molds. And sometimes when you wipe your table, if you leave it there, then there is this whitey powdery thing that is molds. Relatively, they are not pathogenic. Mostly they are plant pathogens. It is the plant that they do give harm effect. There are so many of them, and only 300 have been linked to diseases in animals. So they are animal disease. And human mycosis are caused by true fungal pathogens, and of those, opportunistic one. So when we talk of fungal infection, there may be afflicting our skin, so it may be just superficial, our cutaneous tissue, or even subcutaneous, but we are not after them. We are after the systemic and the opportunistic fungal infection. So when we talk of systemic, usually these are deep mycosis that invades the brain, the lungs, the heart, and other organs as well. When we talk of superficial, cutaneous, and subcutaneous, mostly it is on the skin and mucous membrane. Now, systemic mycosis are also known as endemic mycosis. They are characterized by distinct geographic areas of distribution, and they are caused by bimorphic environmental modes. 90% of these endemic mycosis are initiated by inhaling the conidia of the causative fungi. So the conidia converts to distinctive yeast or spirules in cases of coccidioides, and approximately 90% of the infections occur in immunocompetent individuals. I said immunocompetent individuals. And the infections are asymptomatic and self-limited. Meaning, all of us may have some fungal infection, but we are not feeling anything, we don't have signs and symptoms. And they usually resolve in due time. Now, if this happens in a disseminated form, of course, they are the ones that have immunocompromised host. They are found to be higher in males. Any question of that? So we go to your systemic fungal infection. So there are many forms. So you have inhaled fungal infection. These are your, okay. So you have inhaled fungal infection. Although these are uncommon, some may infect healthy individuals. And these inhaled are commonly seen with your histoplasmosis, coccidioidomycosis. In the North and South America, they are prevalent. Blastomycosis, that is blastomycosis, and paracoccidioidomycosis. They may also be classified in terms of virulence, and there may be intermediate virulent fungal infection of systemic type. And these are your sporotrichs or sporotrichosis, and those dermatophytes of genera, which is Microsporum, Trichophyton, and Epidermophyton. Okay. So again, when you have this systemic fungal infection, the result is most often a mild infection, but long-lasting, no? And resistance is needed, no, to further attack. Occasionally, these infections are more serious and chronic, especially in the immune-suppressed individual. And we have the so-called opportunistic one. When we call the opportunistic one, they infect those who are already sick and those with immunodeficiency disorder. And what are the risks for systemic mycosis, whether it be opportunistic or the systemic fungal infection? Of course, they usually disseminate or become systemic in a patient who are seriously ill or debilitated. Those with malignancies, no? And diabetes mellitus is one of the metabolic problem with increased risk of developing systemic fungal infection. Of course, if an individual is given a massive dose of antimicrobials, no, suppressing the microbiota, the normal microbiota, then there may be this opportunity for this fungal fungus to grow. And those receiving parenteral nutrition in individuals who are addicted to drugs, so in cases of drug abuse, okay, and in those with immunodeficiency virus infection, the HIV virus infection. Okay. And under this opportunistic fungal infection that we're going to talk of, so you have aspergillosis, cytomycosis, not that much, so we will be dealing more with cryptomycosis, Trichosporum belgi, and Pseudolus crea goipi. So one challenging problem that is posed, no, is the diagnosis of this fungal infection. So how do we diagnose them? How do we know that we're dealing with fungal infection? First of all, you look at the patient, no, and get history, where they are exposed to. Okay? So what else? No? Their immune status. For signs and symptoms, it is similar, especially if they have the same organ of action. So I just would like to emphasize that opportunistic organisms are normal resident flora that became pathogenic only when the host immune defenses, no, are altered. No? Example in use of immunosuppressive therapy in chronic diseases, no, such as diabetes mellitus, or during steroids of antibacterial therapy that upset the balance of bacterial flora in the body. So those of you who are in chronic steroids therapy, no, take a look at your skin. You may be harboring a cutaneous form of fungal infection already. So how do we diagnose them? We have a different way. No? So one is microscopy. Then you can do some culture. Then do some serological testing. Check for the histopathological examination. You can do molecular and imaging technique as well. But which one of these will give you a definite answer? Which one? Which one will give you a very definite, yes, I'm dealing with this type of fungus? Microscopy. Your histopathologic technique. Okay? It's a microscopy. microscopy, you have some contaminants there. No? When you are dealing with tissues, no, that is subjected for staining and examination, then this is being removed. Although the presence of your fungal element there is enough for you to decide that you're dealing with fungal infection. Your microscopy is one of the common, no? It's a very, I will not say elemental, but this is a common test, no? That we request if we want to know to identify the fungal infection that afflicts an individual. It's readily available, easy, simple and cheap. Respiratory secretions may be sent, no? Especially if you're dealing with a pulmonary problem and you think that this pulmonary problem is secondary to fungal infection, then you can send the sputum. Or you can do bronchoalveolar lavage and send the fluid. Your microscopy likewise would differentiate septate and unseptate molds. No? And there are molds that will give you this characteristic. And one good thing about microscopy, if you're dealing with a cryptococcal meningitis, that is a very simple and easy way of diagnosing it. You just send your CSF there and ask for Inja ink and do the direct microscopic identification. What about culture? These fungus are easy to grow. Okay? Only be careful with contaminants. No? They usually give a characteristic growth in culture media. So this is a candida on growth. This is your blastomycosis, no? Blastomyces, and this is aspergillus growth. No? Your blastomycosis, no? Will give a wavy appearance. While take note of your aspergillus, no? Aspergillosis, they will give you a dry and powdery colonies. No? So just by the growth on medium, you have a rough idea on what fungus are you dealing with. Okay, so what are the specimens that can be sent? So depending on what is affected, if you're dealing with Pulmonia and you think blood, then you can send the blood. If you're dealing with a CSF affliction, then you do your CSF examination, and you culture the CSF, the urine, the sputum, even the catheter tip can be sent for as a specimen, and the tracheal tube tip, no? Especially if the individual has been in prolonged intubation and they are not getting well with all the antimicrobial that you give, then you think of a possible systemic fungal infection. Even in the neonate, no? We do have that, no? Especially if the baby is already there for quite some time being intubated. It is routine for us to culture that tip and see what is in there. Okay? Now, although most of the laboratories now will have automated culture already. Now, your Candida species is a very common organism. And be aware that if Candida is the one that grew in your culture media, think of a past, especially if it grew very well, then the chances is it may be a contaminant. It is not true reflection of your growth, no? Now, if the growth is sparse, then probably it may be a true one, no? Now, aside from that, now we have your serological testing. So your cryptococcal polysaccharide antigen that is present in serum and CSF, no? Will be a good way of detecting cryptococcal infection. And this detection of your antigen will yield more than 90% no? Positivity as against the India ink. India ink is a wet mounting. Just get there the specimen, raise an India ink, then you look at it at the microscope, no? And that will give you a beautifully structured cryptococcus, okay? Fungus. And even if you culture your cryptococcus, it will only yield 50% as compared to a good positivity in serological examination. Aside from your cryptococcus organism, your histoplasma antigen in the urine and serum can be detected serologically. And detection of antibodies to your Coccidioides imitis and histoplasma capsulatum in serum and CSF. You can do some serological examination with that. Okay, what about histopathologically? This will give you a definite fungal infection. So how do we do that? So you send the specimen, they will preserve the specimen and put it into the block, and they slice the block and stain it, and they will look at the different portion of the tissue submitted. Okay? So though they may be using a special stain there that is appropriate for the organism that you are thinking of. So when you send the specimen, you should always have an impression of what they should look for. It's not just it's not a surprise. Surprise! I found this. No. So you give them an idea of what to expect and what to find. So that is how we do it. So, because basing on what you are thinking of, they will be now appropriate the stain that will be used. So commonly they use the periodic acid shift that is PAS, the gomolin, methenamine, silver, or fluorescent stain, and for candida, even gram stain will do. So if you're just dealing with the candida infection, systemic candida infection, and you send them the specimen, if they knew that you're looking for candida there, then just a gram staining will do. Okay? Now, histopathologically, the evidence of inflammatory cells along with fungus, this will be diagnostic, and this will eliminate contaminants. And again, what is the common fungus that will contaminate growth? Your candida. Okay. With the advent of molecular laboratory now, then we can do some molecular testing, like PCR. So you look at the genome DNA, which is being amplified, and do the sequence typing. So what is the advantage of molecular testing? It will give you a shorter duration in getting the result. After how many days? Just you probably in some molecular testing within 24 hours you have the result already. Okay. And some genetic markers, if it is present, then that will be identified as well. Now, restriction fragment length polymorphism and amplified fragment length polymorphism, those are some of the examination that they can do with your molecular testing. What about imaging? Is it very helpful? And when we talk of imaging, what are we referring? Your X-ray, radiological technique, your CT scan, your MRI. Is it very useful? In what instances will it be of use?
For example,
Yes, So depending on the site, So depending, will it be definitive, Remember that granulomatous formation is not only found in fungal infection. What condition that is very common will also give you a granulomatous TB, So they mimic your tuberculosis. So these are the summary of some of the systemic mycosis. So you have there your histoplasmosis, your coccidioidomycosis, your plasmamycosis, and paracoccidioidomycosis. And you have there the structure, and you have the tissue form that can be seen histopathologically. So yeah, sorry. Sorry for that. So you can see the ovaries, intracellular histoplasmosis in the macrophage, coccidioidomycosis, you have there the spherules, plasmamycosis, it is a thick-walled yeast with broad base, and paracoccidioidomycosis, budding yeast. Okay. So let's go and discuss your histoplasmosis. This is distributed worldwide, and the reservoir of this are commonly the birds and the bats. The birds and the bats and the bees. Okay. Okay, so it is commonly known as cave disease. Okay? Because where can you see bats? Inside the cave. Okay? The most prevalent pulmonary fungal infection in humans and animals is caused by histoplasmosis. And the causative agent is your histoplasma capsulatum. Okay? So your histoplasma capsulatum is a misnomer. This is a dimorphic fungi. They grow as a mold in association with soil and alien habitats. So again, it is dimorphic fungus. It has sexual multicellular saprophytic mycelia, and this is the one that is commonly found in the environment. The sexual single-cell parasitic yeast is the one that most of the individual may inhale and bring about infections in humans. They are small oval yeast cells packed within the macrophages. So if this is the macrophages, you have there the small oval yeast. Okay. Now, infection is not in the plasma cell. Please take note of that. So it is a misnomer. The histoplasma, you can see the plasma there. It is not in the plasma cell, but in the macrophages. Then you have their capsulatum. It is not capsulated. Okay. So again, it is the yeast form that is infectious agent in humans. No? The yeast cells have a white, thin-walled oval bodies. No? And these form a sexual macro and micromedia, also from hyphae and mycelial form is one. Okay. And the conidia germinates by a non-polar body. Non-polar and polar body. So how do one get the infection? So after inhalation within the macrophages, the infection will disseminate to reticuloendothelial system. So from the spore that you inhale, this will be taken up by the macrophages in the lungs, and in the macrophages in the lungs, they will be forming into yeast, and this will be now be able to disseminate to other organs. Now, immunocompetent who inhale a heavy inoculum will develop acute pulmonary histoplasmosis with a self-limited flu-like syndrome. Now, the reticuloendothelial system that is involved will give you the lymphadenopathy. This will give you the enlargement in the liver, okay? And some of the manifestations seen with histoplasmosis. Now, mucocutaneous ulcers in the nose, mouth, tongue can also be seen. Okay? So, radiologically, so this histoplasmosis has two types, pulmonary and disseminated. Your pulmonary, again, come from inhalation, and this form a lesion in the hilar and the mediastinal nodes. So if you will look at the radiologic findings, you will see different affection. So you may either have asymptomatic, you may have acute pulmonary symptoms, you may have mediastinal granuloma, okay, in the middle, fibrosis, mediastinitis, this is a fibrosis, no? Or a chronic cavitary pulmonary lesion. This is a form of fibrous nodule called histoplasma. Now, in disseminated form, and this usually occurred in immunocompromised hosts, then you are able to spread it from the lungs to other organs in the same manner. So, healthy individuals will have symptoms that is similar to your tuberculosis. So, they may be presenting with non-specific signs and symptoms like fever, malaise. Occasionally, they may have some petechial on the skin or skin lesion. Mucous membrane ulceration, hepatosplenomegaly if liver is involved, and enlarged lymph nodes. No? Now, chronic pulmonary presentation occurs in 1 to 100,000. No? So, before an individual can develop a chronic pulmonary problem, so this individual should have a pre-existing structural lung defect already. So those having chronic obstructive pulmonary diseases, or their alveoli is not working well, like in emphysema, no? So they may have a chronic pneumonia or infection in cavities. There may be reactivation and reinfection that is occurring. And mostly they will have apical infection that may be cavitary. In the same manner that you have your tuberculosis. No? So if you will get an X-ray of a person suspicious of tuberculosis, it is the apical region that we do examine. And if you have some streaks there and fibrosis, no? Or cavitaries, usually that's highly suggestive of your tuberculosis. Now remember that if you have systemic fungal infection, this mimics as well your tuberculosis. No? So you may, this individual may present as mediastinal granulomatous or fibrosis, no? Wherein there is fibrous and traction, occlusion of mediastinal structure. Or they may be presented with histoplasma, the earlier graphics that I have seen. It is a fibrocaseous nodules with concentric association and calcification. Some may present as ocular histoplasmosis. It is a presumed ocular histoplasmosis. And they usually present with choroiditis, which may be active or inactive. And this may result in visual loss due to macular involvement. Again, when we talk of diagnosis, be careful with the specimen that you're going to send to the lab, depending on the manifestation. If the manifestation is pulmonary, what specimen do you send? Sputum, if they can generate sputum. Okay? If there is cutaneous lesion, scraping of the lesion. Okay? If there is some lumps or nodularity, then you biopsy and send the tissue. Okay? So again, sputum, blood, urine, even bone marrow aspirate, scraping from the lesion, and biopsy specimen can be used. And you can do direct examination of the tissue specimen histopathologically. When we talk of direct examination of the tissue, it is histopathologically. So after preparing the tissue, then you directly examine it through microscopy. Okay? So you may do periodic acid shift stain, Gomoris methenamine silver stain, or routine histology. Routine histology make use of hematoxylin and AUC. Now, this is sputum. You may have a wet mounting with KOH. Any question? So So actually, this is a summary on what you will see. No? So the modes that may be cultured, no? At 25 degrees centigrade, so you can do culture and microscopy. What you will see is a sexual spore, tuberculate, so this is what you will generate. So when you grow this, then you take a sample, and this is what you will see, a hyphae. Okay? So when the yeast is formed, when you grow them in 37 degrees centigrade, then you stain them, and this is what you will see. Okay? So from the yeast cells, this is what you will be looking at. Okay, 4 and 5, and this is in green. So James's stain of the bone marrow with intracytoplasmic yeast into the macrophages. So there. And tissue section with hematoxylin, you can see those numerous yeast cells scattered there. So culture, we send the specimen for culture and subject them into a rich media culture, such as glucose-6 blood agar or saboron dextrose agar, or you can use the inhibitory mode agar. IMA is inhibitory mode agar. And take note that this has to be incubated for 1 month before you can successfully grow them. So spatial blood culture methods such as lysis centrifugation can be also done. Now, serologically, you can do complement fixation tests for antibodies to histoplasmin, or yeast cells become, and this becomes positive within 2 to 5 weeks after infection. What is the implication of that? Knowing that your serology will be positive within 2 to 5 weeks, meaning if you are suspecting of a fungal infection, you don't do serological tests right away. So you count, when was the symptoms begin? And from there, if you think it is the infection already, you count, because you need at least 2 weeks, after the infection. Okay? And one of the most sensitive tests is your radioassay or enzyme-linked immunoassay for the circulating polysaccharide antigen of your H. capsulatum. And if you're dealing with disseminated histoplasmosis, nearly all patients tested for this will yield a positive result. Any question? So we now go to your coccidioidomycosis. Your coccidioidomycosis is caused by 2 species, your Pseudodacea, Posadacea, and your Imitis. It is an endemic in well-circumscribed semi-arid region of the southwestern United States, Central America, and South America. What does it mean? Why do you have those endemicity? So if you go there and you got sick, and if you are immunocompromised, then you know what form of fungus you may be harboring at. Okay. Although infection is usually self-limited and dissemination is rare, it seldom go widespread, But this infection is always a serious one, and it may be fatal, causing death. The good thing about it, there is no human-to-human transmission. So in short, you need to inhale the spore. Okay? So there is the pathogenesis. The mold with septate hyphae form arthrospore. Then when the arthrospore is formed, it will fragment into your arthropodia. Maghihiwa-hiwalay sila. So So you have there a single, no? Acrocornea. So this one, 1, 2, 3, 4, 5, okay, no? Then this acrocornea will be inhaled, and there goes, no? And this acrocornea becomes spherules. There. This is spherules. This mature and divide and will release endospore. And endospore that is released will be the one to bring about dissemination. Okay. So inhalation of this one, no, in 60% is asymptomatic. Okay. So meaning you're harboring, but you don't have any symptoms. No? Now, 40% of individuals may develop a self-limited influenza-like illness. No? So when we talk of influenza-like, we have fever, malaise, arthralgia, and headache. No? This coccidioidomycosis is commonly called valley fever, San Joaquin Valley fever, and desert rheumatism. Okay. So on radiologic examination, patients typically show hilar adenopathy, no? Along with pulmonary infiltrates. No? So there is no, this is abilateral, so you cannot see the hilar enlargement. Although pneumonia, pleural effusion, or nodule formation may be present. No? Now, pulmonary residual occur in about 5%, and usually this is in the form of your nodule or thin-walled cavity. So, seemingly, the radiologic findings in coccidioidomycosis is not really very specific for that. No? Only it is telling you that this can cause this damage to the lungs. No? Now, extrapulmonary site may be involved. The most frequent organs for dissemination or involvement are the skin, the bones, the joints, and the meninges. No? Now, some may develop a chronic but progressive pulmonary disease, no? With multiplying and enlarging nodules, and sometimes this may become cavitary. So you may have an X-ray cavitary lesion. On histologic examination, a typical granuloma with giant cell and interspersed suppuration may be seen. Now, diagnosis of coccidioidomycosis is on direct examination or histopathologically, no? Is made when you find spherules and endospore. That is diagnostic for coccidioidomycosis. Okay? This is done in culture, ambient temperature. This produces a highly septic hyphae. So you can see they're greasing. And arthrochonidia. And in here is the spherules. No? Large spherules containing endospores, no? Can be seen. And this is a lung tissue specimen. Okay? Any question? Any question? So again, diagnostically, so you may have a direct examination of the specimen. Then serologically, 2 to 4 weeks, IgM is detected by your latex agglutination test. The specific IgG may be detected by immunodiffusion or complement fixation. I just would like to emphasize that if you're dealing with HIV patient, this is often negative. So what is the implication now? So if you're dealing with immunocompromised patient, do not do serological testing, okay? Because you will not, there is no yield that there is no result that will be fruitful. Now, skin testing can be done using your coccidioidomycosis, no? So this is similar to your tubercular testing, no? Your PPD. Your what is PPD? PPD? Protein purified derivative, or purified protein derivative. And that is a skin test for tuberculosis. So this one, you also have a skin test, no? And to become positive, you should generate a 5 millimeters, no? Of wheel or reaction that is seen 24 to 48 hours. Meaning you do the testing, you read the testing 24 to 48 hours after. Okay? Any question? Any question? Then we go to your blastomycosis. Your blastomycosis can cause a chronic infection, again with granulomatous and suppurative lesion. Initially in the lungs, and may disseminate to any organ, but preferably in the skin and bones. No? It is caused by your dermatitis, no? Blastomyces dermatitis, which is typically a dimorphic fungus that grows as a mold in culture, producing hyaline, branching septate, like this one, and conidia and simply budding yeast in the host. No? In culture, colonies usually develop within 2 weeks, no? And this is how it looks like in the culture. What do you imagine if you see this? Sunny side up. Yeah. Very good. You're eating egg every day. Okay. So, what is the biology of this blastomyces? No? So, in the environment, it exists as a mold. No? So this one, that is the existing form. Okay? So, what happened now? No? The hyphae produces spores, no? Which is either inhaled or inoculated into the skin of susceptible host. No? Now, inside the host, okay, so there you go, so you have there the body, then it will be taken up, no, into the blood. No? So inside the host, it is transformed into a broad-based body yeast. No? From the lungs, it disseminates to blood and other body parts. So what is the most common clinical findings? Pulmonary infiltrate that cannot be distinguished from other acute lower respiratory tract infection with associated non-specific symptoms, like also in tuberculosis. No? So patient can also present with chronic pneumonia that does not improve no matter how much antibiotic you give, because you're not dealing with microbes, but rather fungus. No? So histologically, you have a distinct granulomatous reaction with neutrophils and anti-shading granuloma. So this is what you will see. No? Okay. In the lungs, no? Non-specific findings. So how do we treat? In severe cases, no, you can give amphotericin B. In patients with confined vision, 6 months course of itraconazole is very effective. Now, your blastomycosis is relatively common in dogs, and the natural habitat is unknown. So you have this can be seen in rural river banks, no? So there may be some small outbreaks there. So although the rivers that we have here is what? It is not mold that you will see there. No? Yeah. Okay. Okay. What about your para-oxygenomycosis? No? So it is the brasiliensis. No? Again, it is thermally dimorphic fungal agent, no? That is seen mostly in South America, which is confined to endemic region of your Central and South America. So morphologically, this is how you will see them. No? Yeah. So these grow very slowly. No? At 36 degrees centigrade, you need a rich medium, and it will you will see the body. Okay. So that is the growth bubble that you will see. So, serologic testing is the one that is very useful in this condition. No? So, for the diagnosis, no, you can check the antibodies to your paraoxygenolin that may be measured by complement fixation and immunodiffusion. Okay. Any question with that? Then we go to your opportunistic mycosis. So opportunistic, because given the opportunity to grow, they will grow. If you don't give them a chance, then they will not. So don't give them a chance. And how is that possible? How is it possible? Make immune system, no? To strengthen your immune system. So these are caused by fungi that are either member of the human microbiota or environmental yeast or molds. No? The incidence and severity and mortality of systemic opportunistic mycosis are the highest. No? So meaning to say, if you have opportunistic candidiasis that becomes systemic, no? And you have not done anything, this patient will not die of the previous infection, but die of fungal infection. Okay? Now, successful management usually involves early diagnosis, no? Rapid administration of appropriate antifungal therapy, and control of underlying condition or disease. So in short, if this patient is diabetic, who develop opportunistic infection of candida, no? You treat also or you control the blood sugar before you can treat, no, your candida. No? Otherwise, it will just be a cycle. So let's go to your candida. So again, these are the So these are the opportunistic. Your candida, your streptococcus, your aspergillosis, your mycosis, and your pneumocystis pneumoniae, and your penicillosis. So let's go first to your candida. This is the most prevalent systemic mycosis. Okay? So it is the most common agent, but take note that this is a normal flora of the skin, mucous membrane, and gastrointestinal tract. So meaning, if you scrape your skin and send them to the laboratory and identify candida, that is possible, especially if you're not taking a bath. Okay? If you have there in your skin whitish lesion that is itchy, have it scraped and send it to the lab, do a wet mounting, and that is candida. Okay? But this is easily being treated. So candida infection can be cutaneous and be systemic. No? So in cutaneous, it is caused by increase in the local numbers of your candida that has the opportunity to damage the skin and epithelium. So meaning to say, before you get the disease, you should have a number of load. No? So before you can call somebody, you should have a load. Unless you are unload. Okay. So systemic, it occurs when the candida enters the bloodstream and the innate phagocytic host defense are inadequate to contain the growth and the dissemination of the yeast. So meaning, if they get entered and there is no guard, so you know they can drug you. Okay. So your candida is a unicellular fungi that typically reproduce by body. So you see how beautiful they are, no? And, so it has an ability to exist in both yeast and hyphal form. So again, they are dimorphic. And you may find pseudohyphae. These are yeast cells that have elongated and remain attached to each other with non-straightened ends. Wala akong picture. So what are the different factors that brings about this candidal infection to become systemic and become opportunistic? Okay? They have these polysaccharide proteins and glycoproteins that will facilitate attachment and invasion of the host cell. Okay? They also, some of these species produce a family of glutamine sequence surface glycoprotein, which are adhesins that bind host cell membrane receptor. So they facilitate the attachment, then they adhere to the host receptor, and they are able to degrade the host cell membrane and destroy the immunoglobulins, and that is the aspartyl proteinase that is produced by your candida. Now the yeast itself form a biofilms, so they have some covering, they have some protection to protect them from extracellular matrix material and resist penetration by host, immune response, and antifungal drugs. So those are the characteristics of your candida. Okay. So you have your chronic mucocutaneous. These are form of your candida. This is the presentation. This chronic mucocutaneous candidiasis is rare, but distinctively the clinical manifestation is characterized by granulomatous candida lesion. So if you have seen individual with this one, then they have this candida lesion, in the mucosal surface. This is a vulvovaginal lesion. Mostly you have a milk-like discharges, and sometimes you have their adherent, white lesions, And systemic candidiasis is usually seen in indwelling catheters, in some surgical procedures, in individual who is abusing drugs, or damage to the skin and gastrointestinal tract. So in immunocompromised individual, you may have a cold lesion in the skin, in the kidneys, in the eye, in the heart, and even the meninges. Unless you have a good history, you would not know that they are suffering from one. So diagnosis, again, direct microscopy, culture, molecular method, and serology, and those are very helpful, except for this serological examination that will not help you. So just by the growth, you have an idea that this is already a candida. More so if you have seen this hyphae with bolus on this one, especially in saborod agar. They grow within 48 to 72 hours at temperature, at body temperature, and they will give a white colonies. So any question with candida? Yes.
So, regarding treatment or management, is there any value to using probiotics?
Probiotics.
Because
what is probiotic?
If the etiology of mycosis is the result of alteration in the normal flora, is there any value?
Well, if you will look at it, what your probiotic will do, it enhance your immune system. They have a series of strategies regarding that, And if you enhance your immune system in a certain organ, your probiotic is primarily used for GI problem. Okay? Then probably that area will not be affected by your fungal infection as well.
Because that has been used as a marketing campaign by Yakult, for example.
So your Yakult is actually they are for promotional. This is used to enhance the GI immune system.
Yes, but in other countries, they attempted to go into cosmetics with Yakult. I don't know Yakult lotion.
Actually, even your stem cells. How do you find the stem cell to be useful in if this is applied to the skin? The same way with that. Although with that, they are having some studies, but they have not proven anything.
Okay.
But for the GI, yes.
The question, Dr. Fungal infections, like candidiasis, how do you confirm that there are occult lesions?
Oh, confusion. You answer that. You answer that. When you say occult lesion, you cannot find anything, right? But symptoms-wise, they are there. No? So what do you do now? If you cannot find anything, then you make you suspect. Given the scenario that this is immunocompromised, given the scenario that candida is very common, then you hit it by suspicion. Then you do some culture, then you don't find anything, but there is a manifestation. So what do you do? Empirical treatment. That is what you do. You cannot say anything, but you're thinking it's secondary to that, then you might as well treat. Okay?
What will be the empiric treatment?
The same treatment. When I say empirical treatment, what do you mean by empirical treatment? Ayan, malawit tayo.
Doc, once will you prescribe it?
What do you mean by empirical treatment?
We don't know the exact cause, but we are giving out based on the right
Okay. So if you're thinking it is a serious fungal infection, then you have something that you can give that is very good at that. Depending on what you're thinking. If you're thinking of candida, if you're thinking of coccidioidomycosis, if you're thinking histotoxinosis, then you can give empirical treatment that is good for that. Then probably your amphotericin B
Not adults.
is raconazole maybe.
The patient is immunocompromised.
Yeah. More so if you are dealing with immunocompromised. No? So actually that is what we do in a patient who is in prolonged hospitalization. And if we can see some mucocutaneous lesion, no? Let's say in the mouth, they already have whitish lesion, then you send them for culture. And with this candida, then we start. You don't wait for them to become systemic. Especially if you're thinking that this is already in a scenario that the immune system is already compromised. No? And you can see that in mostly hospitalized patients. So do not get surprised. Why is this patient having high-grade antibiotic already? Then you have antifungal. Then it is only antiviral that we don't give. But antifungal for long-staying patient, we do give it. Okay. Any question?
Doc, just one more question. Doc, regarding clinical findings for example, oral thrush, would, other than the visual symptoms, would,
Oral thrush?
Yeah, oral thrush. For example, candidiasis, oral candidiasis. So would, something that's, if the patient's breath smells like bread, would that be,
What?
would that be helpful?
Which one?
For example, oral candidiasis. Then patient's breath smells like yeast or bread. Is that helpful?
No. Even without the candida, probably the breath is awful. So you ask them to to brush their teeth. No, in pediatric, we commonly see oral candidiasis, no? Especially those children having their bottle feeding. The milk bottle is always on their mouth. We always see that. Okay, so we go to your cryptococcosis. So again, this is how cryptococcosis goes to the CNS. No? Through inhalation of desiccated T cells from the lungs, it may lodge the CNS and cause meningoencephalitis. No? Although they may also infect other organs like the skin, the eyes, no? And prostate. But the major clinical manifestation is of chronic meningitis. And this chronic meningitis may resemble the brain tumor or brain abscess, no? Or you may think of degenerative CNS diseases, no? Of any mycobacterial or fungal meningitis. So, what now will be your proof that this is cryptococcosis? What will be your proof? This is not that common. But if you have a patient with meningitis, or a patient that is presenting as breakthrough, how will you suspect that this is cryptococcosis? History pa? Oo, not immunocompromised. Geographical area, okay in the Philippines. So you think of the birds and the bees, no? Especially, are you harvesting pigeons, not eating, no? Because this is from inhalation. Are you raising pigeons? Or are you raising chickens? Mostly pigeons, kaya you have better pigeons, birds and the bees, no? Yeah. So you have there the exposure, no? Exposure is very important. Because the clinical manifestation of a CNS problem here is non-specific. Okay? Yan, so meron ka ba? But if you're dealing with the, compromised patient, then at least it's very rational to send those specimen, no? Especially your CNS. No? So if the major manifestation is a meningitis, then your specimen will be a CSF. So this is what you will find on wet mounting of Indian ink. Indian ink preparation of CSF showing typical yeast. No? And there you have there. So surrounded by characteristic white gelatinous capsule. And this is a beautiful presentation of that. No? And this is what you will see. In cultures, now you have a you can see a reflective, a very shiny broth. No? But this is not typical. This is not very specific. No? You can see this in other organisms. So once you see that, you get the diagnosis that this is Cryptococcus neoformans and this is Cryptococcosis. Any question? Then we go to your aspergillosis. So this is a type of disease, and the severity of this depends on the physiological state of the host and the species of the aspergillus involved. No? So the etiological agent are cosmopolitan, and this include your Ubigatus complex, Glabus complex, Liger complex, and the Nidulans. No? And it is Aspergillus Ubigatus that is more common. So again, the spectrum of disease of humans and animals caused by members of genus Aspergillus. And the diseases include the following. It may be a mycotoxicosis due to ingestion of contaminated food. It may be an allergy and sequela to the presence of conidia and transient growth of organism in any body orifice. Or there may be colonization without extension in cavities in cases of debilitated tissue. Or this may become invasive, inflammatory, granulomatous, and even necrotizing disease of the lungs and other organs, although this is rare. Okay? Now, systemic and fatal disseminated disease. No? So this is fatal. Okay? So what happened in the lungs? Alveolar macrophages are able to engulf and destroy the conidia. Now, in corticosteroid-treated or immunocompromised patient that has the ability to contain the inoculum, then the conidia will swell and terminate and produce hyphae that have the tendency to invade pre-existing cavities. No? And that it will bring about the so-called aspergilloma or fungus spore. Now, your aspergilloma occurs when this inhaled conidia enters the existing cavity where they terminate. No? Now, some of these patients may go asymptomatic, but since it is the lungs that is involved, then you may have non-specific symptoms like cough, dyspnea, weight loss, to the extent of coughing out of blood. No? Radiologically, this is what you will see, a circumscribed lesion there. No? That although radiologic will not give you a definite answer that this is aspergilloma, no? But that is just a suspicion, and this is just on a higher magnification of what you will see. Now, invasive aspergillosis, no? It will invade the lumen and walls of the blood vessels, causing thrombosis, infarction, and necrosis. And that is why this becomes a fatal disease. So again, diagnosis by direct microscopy and histological examination of the sputum or even wet mounting using KOH. And you will see the hyaline septate there. No? And this is how it grew at room temperature. Now, this species may be identified according to morphology of their conidial structure. And histologically and by direct examination, this is how they look like. Don't worry, I will not ask you to describe that. Now, I just would like to emphasize that antibody tests are not helpful in the diagnosis if you're dealing with invasive aspergillosis. But if you will do your cell wall galactomana, that is diagnostic. Do not ask me what is that. That is a form of examination, laboratory examination. Now, let's go to your mucormycosis. Your mucormycosis is also known as black fungus. No? It is an opportunistic mycosis caused by a number of molds in the order of Mucorales, of the Pilo, Glomerulomycota, genera Rhizopus. No? So, what is the clinical findings? No? So, you have the rhinocerebral mucormycosis affecting the nasal passage of the blood vessels, and this can cause thrombosis, infarction, and necrosis. The patient develop edema of the involved facial area, or if it is near the eyes, then it can bring about orbital cellulitis. You may also have thoracic mucormycosis through inhalation of the spore. So again, diagnosis is a specimen, and this time your nasal discharge, tissue, and sputum may be subjected to testing. And mucormycosis will show you a ribbon-like. Yeah. Ribbon-like, sparsely septate. That is how your mucormycosis looks like under the microscope. And this is your growth in the culture region. So this is the lesion that they will, that your mucormycosis will bring you. You have an S-star. This is a necrotic tissue. So if this on the facial area, then what we have to do is to aggressively debride that. No? Then rapid administration of antifungal drugs, then control the underlying disease. Those patients who survive may have some residual effect, especially if it is on the face. No? So this patient may have facial paralysis or loss of vision or loss of an eye. Any question? Then you have your pneumocystis pneumoniae. So this is classified as cyst on the basis of molecular analysis. And it is acquired by inhalation and commonly seen in patient who has human immunodeficiency virus. No? Actually, prior to the introduction of effective chemoprophylactic regimen, it was the major cause of death among AIDS patients. And what chemotherapeutic regimen is very effective for this pneumonia? Your otrimoxazole. Okay? So clinical findings, no? Similar to other fungus that involve the lungs. So diagnosis through findings of cysts of pneumocystis in bronchial lavage. PCR-based test can be used. Again, serological test is not useful because most of them are immunocompromised. So treatment, your trimethoprim, sulfamethoxazole, or pentamidine acetionate. No? So your penicillosis, no? This is a penicillium. Okay. Found in several regions of Southeast Asia, including China, Thailand, Vietnam, Indonesia, and even Manipur state of India. So bamboo rats are the only other known host. So what will happen if you have penicillosis? Yeah. So aside from Punchinnia, you may have some skin lesion and systemic involvement of multiple organs, especially the reticular endothelial system. You have non-specific signs and symptoms, and you have 70% with or without AIDS develop cutaneous or subcutaneous papules. So this is how it looks like. It is the neck area and the back. And on the face, no? So diagnosis, of course, a finding of your fungus under direct examination, no? Either from the skin, the blood, or tissue biopsy. And this is established by microscopic observation and positive culture. So what treatment option do we have for penicillosis? Okay, you give amphotericin B for 2 weeks, followed by itraconazole for 10 weeks. Without treatment, 90%, more than 90% of them die. Okay, what other treatment options do we have for other fungal agent? For invasive candidiasis, no? Fluconazole is the drug of choice for empirical therapy in patients with candidemia without sepsis or septic shock or recent exposure to azole. Because your fluconazole is an azole. So if this patient has previously used azole, then that will not be your choice, no? So with previous exposure to azole, then you use your amphotericin B or capsopungin. In severe sepsis, your capsopungin is the drug of choice. No? For microbiologically documented candidiasis, no? Then fluconazole is the drug of choice. No? For your albicans, tropicalis, and paraceliosis. No? For brucei and galbrata, it is caspofungin and amphotericin B. What about for aspergillosis? No? Voriconazole as the primary therapy, salvage therapy, you have there voriconazole, amphotericin B, capsopungin, especially for refractory cases. No? Or you can use combination therapy. If you are not sure that this is aspergillosis, but you're suspecting that you're dealing with a fungal infection, then you can give empirical therapy of amphotericin B, especially in patients with neutropenia who is persistently having some fever. For cryptococcosis, no? So for cryptococcosis, what do we give? Since you're dealing here with the CNS, no, then you have to find that the drug that you will be giving should pass the blood-brain barrier. And amphotericin B and flucytosine, no, can be given for 2 weeks, no, followed by fluconazole and itraconazole or itraconazole for 8 weeks. For asymptomatic or mild diseases, then you just give oral fluconazole or itraconazole for 6 to 12 months. and this is followed by secondary prophylaxis. What about for mucormycosis? Of course, we have mentioned that already. So you should have surgical resection and debridement, followed by high dose of amphotericin B. And in those patients who cannot tolerate or already refractory, no, then you can use posaconazole, given 4 times a day. But still, the prognosis is poor. Any question? Any question? Then, these are the references. I think that is my last slide.